I'm going to focus my talk on CT and TEE. And the point of this conference really is the merger of echo and CT and where we need to go with fusion in the future. And also where we are as not only as cardiologists or radiologists or sonographers or technologists, we really need to be a consummate interventionalist. So one thing I'm going to ask everybody to do is stop thinking like whatever your profession is and start thinking like a device. The minute you start thinking like a device and thinking how a device can actually cause problems, the safer the patient's going to be. And that's how I go about planning. I was trained as a cardiologist and an imaging cardiologist, but then when I went to structural heart, I realized the deficiencies that we have in imaging and what we need to go with industry from now on. So this is basically the role of structural heart, CT and 3D TEE. We don't mention cardiac MRI. Cardiac MRI is not robust enough yet right now. 5 millimeter slice thickness. We're dealing with a patient population about the age of 80. They can't hold their breath for more than 45 seconds or 9 seconds, and they can't do it for an hour. And most of them have a pacemaker lead or a device. And most of them will not lie still for 2 minutes on a TAVR CT table, let alone 45 minutes on an MRI table. So when we get to the low-risk population, we can think about doing cardiac MRIs, but we won't get the legs either. So CT and TEE is what we work with. The role of CT and TEE really is to define what is the anatomy and pathophysiology of the disease state we're dealing with. Where's a shunt, where's a hole, where's a valve problem, what are we going to plug, and what are we going to stuff? It's also to tell us where the catheter is going to be going. Where is the catheter guidance supposed to be? Where can the catheter go? Where should the catheter not go? And you want to anticipate. One of the things that I learned in my training was I learned the best TEE skills from cardiac anesthesiology. And my nickname by Adam is Chicken Little. And because that's when I started anticipating and seeing so many complications, that's where we go into and get the 65 data points to prevent the next complication on the table. And cardiac anesthesiology, the way that they're trained, they're phenomenal physicians. They understand every single surgical procedure and can recite what a surgeon's going to do step by step without ever having touched a scalpel. They know it probably better than the resident surgeons. Well, I know for sure they do. At least Mike Isley knows everything well in the back, left, right corner here. Not only do they know that, they know what to do if a complication happens. Epinephrine, norepinephrine, dobutamine. Would you guys please move your scalpel, move your hand, take the valve out. You're obstructing the LVOT. I need some blood pressure here. They know how to do all this anticipation. As a cardiologist in a non-invasive lab, what we do is we put a probe down the patient's back throat, look at the left atrial appendage or a TAVR or any kind of aortic valve, pull the probe out, 15 minutes, our RVU is done and we're out of there. The problem, though, is we got to really think about now, what are we looking for? What kind of valve abnormalities, and think like a valve. The minute we do that, the safer we're going to be. When we're doing this now, we got to think about complications and how to avoid the complications. So I'm going to actually shock you with this presentation. I'm going to show you the complications that we've had over 5-6 years. But we're a high volume site. We do over 60 MitraClips per year. We're the commercial top site in the Midwest. We do over 70 Watchmans per year. We're #1 commercial site right now. And we do over 200 TAVRs per year. So as you can see, this will be a range of complications you're going to see, but it's not our usual norms. I don't want to scare you guys. And the other role for imaging is to do the post-survey results. What are we looking for? Is the valve functioning? Is the device functioning? What should we scan for? So the main procedures I'm going to touch on today, for the sake of time, is TAVRs. And at this institution, they're old. Everybody does them. We have over 16 TAVR sites in the state of Michigan. You can imagine how tough that is and how competitive that is, and to still get 200 patients in a year. We're also going to now do TIMVRs. TIMVRs are in, transcatheter mitral valve replacements. Our echosonographers here have been amazing, and our cardiologists have been amazing in the echo lab, trying to read these studies with these devices that we put where and why. And the plugging and the clipping are not going away for the perivalvular leak closures and MitraClips. They're here to stay. So you're going to be seeing a lot of new innovations, and then be prepared to see new objects in the heart in the next 5 years. A lot new devices are coming out, and a lot more procedural plans that need to be done. So to start from the beginning, if you're starting to build a 3D lab or want to be a 3D structural heart imaging specialist, the one thing on the left-hand of the screen is you can see how minimalist we are. That's Bill and Adam there doing a transcatheter femoral procedure, and what you don't see is where I'm at. So on the right side is where I'm at, behind the 6-foot lead shield because of radiation exposure. So if you're going to start a lab up, make sure you have radiation protection. For interventional cardiologists, they most commonly get brain tumors on the left side of the brain because they're on the left side of the C-arm. For people like me, it's brain tumors on the right side of the brain because I'm right-sided with my arm over on the right side. If you're a cardiologist or a sonographer going into the cath lab, you always want to make sure when you get your lead to actually get shielding on your right side, depending on where your C-arm is going to be at, because you're not going to get protection there. You're not going to be standing horizontal or parallel to the plane of the C-arm beam. You're going to be always on the side. So make sure you have extra protection, and females, extra breast protection. My leads are actually double-leaded for purposes of protection. And so far, industry hasn't designed anything for an echocardiologist in the lab yet, so you just have to jerry-rig and make sure you're protected. Lead shielding at all times for your eyes, too, for cataracts. The imaging setup is very important in the cath lab for you to be performing a TEE. The joke is I'm just a TEE probe holder in the cath lab. You can be a TEE probe holder, or you can actually be involved and become Chicken Little. And the way to do this is to really become entwined. And with my imaging fellows and with the cardiology fellows, when they come in here, they always hear me rant and go, your right eye is going to be on your echo screen, on whatever machine you have. Your left eye is going to be on your fluoroscopy screen and going to be a chameleon on purpose. And your right ear is going to be hearing what the interventional cardiologists are mumbling under their breath. And your left ear is hearing what cardiac anesthesiology is saying about the blood pressure, so that you can merge all of these. So you can be multitasking all the time. Great for females, okay? Now, when we're doing this, the way that I have it set up, on the bottom right hand of my screen is the head of the table. So the patient's head is towards me, and that's my shield. That green glowing arrow is my echo machine. The echo machine, when I'm standing there, if you take a look on the top left now, I've got two monitors. And on there is my fluoro screen. I need to see fluoro at all times. If I don't see fluoro, I'm not an active participant in the structural heart team, and I'm not going to be seeing the complications that the team is going to be seeing. I'm just going to be a regular cardiologist that won't understand this procedure. However, if I can see the fluoro screen, I can see exactly when the procedure is going to have a complication, and when a balloon ruptures or a valve embolizes, I can call that out first. I also see the blood pressure at the same time. So if my mitral regurgitation severity increases after MitraClip's there, I know why. And it's not because of my aliasing or my gains, my echo machine. I can see the blood pressure went up, the blood pressure went down. And on the top right-hand screen is a huddle. That's Adam, Bill, and Marvin getting really excited about a device being pulled out on a paravalvular lead plug. And that's just a reminder, listen to what they're saying, because they're gonna not try to remember or tell you. They had to make sure the patient is safe. Their job is not to tell you, oh, I wish I could see this image better. I wish I could see that. That's where you gotta anticipate this. That's enough for the imaging setup. For a basic TEE probe, on the left is a glide scope image. So what is very important when Mike captured this image actually is where you put a TEE probe. For our fellows, we don't know that we can utilize this. A glide scope, you should never have a complication intubating a TEE in an anesthesia suite when you have a glide scope available. Use your technology. You shouldn't be injuring a trachea, you shouldn't be causing a perforation. You should have pure visualization, but you have to be available that the tool is there. And now you know why patients being MPO, because they have a lot of gunk and suctioning problems in their esophagus when they're putting the probe down. On the right is a TEE probe. The reason I put that TEE probe, is because the main thing you want to take a look at the surface of the probe. So on that surface of the probe, if you can take a look, there's actually a scratch on it. When we put bite blocks in the patient's mouth, as you pull the TEE probe out, you can actually cause a bite mark on the probe and scratch the surface of the probe. Each probe is about $25,000. When there's a scratch on the surface of the probe, that probe is not going to operate for a 6-hour MitraClip case. So you always want to check the probe surface before you actually put the probe in, or else you're going to be you better have gone to the bathroom before you went to the MitraClip case. So we're going to start with TAVRs, and then we're going to ramp it up. So Tina did an excellent presentation about why we obsess so much in the CT lab, what the role of the CT technologist is. For us, we bring everybody into the structural heart team, and everybody is involved and feels invested, because these patients have less than 6 months to live, hence they're coming here. So they can't come back for a rescan, they'll die. So our techs understand that very well, and they have this passion and drive for it, and they've gone above and beyond in doing all this for our patients. I have a double arrow here complementing TEE with CT. Neither one is superior. You'll hear the camps say fluoroscopy is the best, other camps say CT is the best. That's what Vancouver will say. In the New York, Columbia, Becky Hahn will say TEE is the best. In the Midwest, in Detroit, we say we like both. Why? There's a few things to think about. The major things that can go wrong in the case. On the bottom is death, but there's a few steps preceding that before the patient dies on the table. If we undersize a valve, we get systole and diastole mixed up and put the wrong valve in, the valve can embolize. We can't take them to the OR, and we can't operate on them because they're high risk and they've been deemed non-surgical candidates already, so they're screwed. And they're 85 and they're really cute. If you oversize the valve, because you over-measure the calcification, or you don't understand the analysis anatomy of the aortic annulus, you can cause a type A dissection on the table. It's happened. And patient's not a surgical candidate. They're screwed. If you put a valve in and you just looked at the aortic annulus, which is how automated software does. Now, one thing I want to caution everybody about is there needs to be human oversight for any kind of computer automation. Every single software tool has an assumption, so you need to oversee this. If you assume coronaries are certain heights or not certain heights, and you don't look at it yourself, you can obstruct a coronary and a patient can also die. We've had that happen before too. You can also do femoral vessel injury. One of our cardiology fellows, Brittany Fuller, did an excellent presentation at NASCI last year to a group of radiologists, and the poor thing got traumatized, about how to measure femoral vessels. So a typical 3D lab, if you think about it, 3 years ago was designed for vascular surgery. 3D labs were not invented for interventional cardiologists who are just plumbers. We're surgeon wannabes or just plumbers. And I'm just an interventional cardiologist wannabe. So when you have femoral vessel injury, if we measure external to external diameters for a femoral vessel, like you would do for an endograft, or you would do for a type A dissection, for anything that's transmural, we're going to kill a patient on a table and have them lose a limb, because that 5 millimeter or 0.5 millimeter difference is going to be a difference in the femoral catheter sheath. That's a 30% complication rate you can achieve and actually decrease if you go inner to inner measurements, which is how we do it at our lab specifically. Stroke, something to be anticipated for too, and other things that can go around, death. So this is a 29S3 valve being inflated external of a patient. We didn't use this valve. And the reason we show this is basically how the balloon inflates. This technology is really cool when you take a look at it. What really is scary is that most valves right now for the transcatheter heart therapy world for our patient population is non-retrievable. Only 2 valves are retrievable, and only for certain sizes. What that means is you have a one-shot attempt at a patient who's not a surgical candidate to get the valve placed in the right place at the right time and hope that it works. The right measurements were done beforehand. These patients are very frail, and like I said before, there's no bailout options. There's a lot of different sizing charts for these valves. When you look at them, it gets more complex and more complex, and they get bigger and bigger. The rate of error for sizing is about 10% to 15%, so that's about 20 square millimeters of area between one valve size and another valve size. And sometimes it's a guessing game, sometimes it's just like, I'm gonna pray. So there's a modern dichotomy of echo and CT that needs to be understood when doing the sizing, getting ready for this. Even before we get to TEE, traditionally what happened 3 years ago is that if you think about the cardiac CT, it was designed for a cardiac radiologist and a cardiologist to read about coronary anatomy. And the heart is quietest in the diastolic phase when it's filling. So all of our measurements were done in, quote, 70% or computer-generated algorithm of diastolic phase. In diastolic phase, though, by echo, all of our sonographers will note that that's the smallest time because the valve is actually going to be closed. It's not open and there's not blood volume going across. So you can imagine how much perivalvular leak we had in these patients and how much undersizing device embolization we have for these patients. So the best cardiac phase is actually going to be manually adjusted to see what the true phase is based on the patient's calcium weight, their leaflet function, and their motion. But even when we do the exact sizing and measure it correctly, on the right hand of the screen you're going to see what's called perivalvular leak. That's contrast in that curly Q little catheter in the right hand screen next to the TEE probe. And all that blackness going into the bottom 4 o'clock position is the left ventricle, should not be there. That's severe perivalvular leak. The reason being is we didn't account for everything else around the annulus. So this is thinking outside the box. Why is this important? It's been well documented and it's been well experienced at Henry Ford Hospital too, that if you have more than moderate severe perivalvular leak at 2 years, patients, 50% of them who had this condition will die. So we lost half of our patients in the first population we did have moderate severe leak within 2 years too at Henry Ford Hospital. So we did give them 2 more years of life, but they could have gotten more. As our transcatheter valve technology gets better, patients demand better too. So there are only 4 to 5 transcatheter heart valve sizes per industry company right now. And if you look at everybody's suits that they're wearing, everybody looks very nice today. You all have a different size. You all have a different size shoe too. There's more variety that you have in your clothing and in your car function and in those dream Tesla cars than we do for a human transcatheter heart valve. So humans are really underrated compared to a car. The concern is that we're moving to a low-risk patient population. So Henry Ford Hospital is the only hospital in the state of Michigan that has a low-risk registry for the Edwards trial, which means that patients who are candidates for open heart surgery are going to be randomized or presented for possible transcatheter heart valve intervention. These are no longer the 95-year-old cute little old ladies who don't have any other options. These are the 65 robust people that could have gotten a sternotomy and open heart surgery, but deserve better with a one-shot attempt still. So I used to always show this picture, and it shows the open heart surgery in the far right-hand side, sternotomy. It just doesn't look painful enough. On the far left is the transfemoral axis, and since then we've come across a transcarotid, where we go from a carotid axis. We've done transcaval. We also do transapical. We've gone away from transapical because it hurts patients too much. They have too much healing time because the intercostal nerves are there. And we also do transaortic, but transcarotid is a straighter shot. This is more visual. So on the right is an open sternotomy. So that looks more painful. That's a patient in there. And on the far left is the Cath lab. And the emphasis is on the title of this slide. It's 2016. So in the right is the gold standard. A surgeon can feel everything. They can manipulate, they can see everything three-dimensionally. Why do we need CT? Because we can't see with the TEE probe, and we can't see with the MRI, our 3D volumes right now. On the far left-hand screen is 2016 technology in our most advanced Cath lab that anybody has right now. It's black and white, and it's 2D. That's the problem. So when we're doing this, CTs and TEs had to complement each other. When you're moving this on the far left-hand side, on a traditional 2D TEE, if I call Guillermo, our lead sonographer here, to say, hey, can you look at the TEE or get the echocardiography for me and get the image of the aortic annulus is the largest, there's no way unless we actually sweep through the whole aortic annulus back and forth with our probe actively to know if we're cutting the aortic annulus by TEE or echo at the right cross-sectional plane. On CT, we can scan in and out to know that we are truly at the right phase. That's a lot of limitations there. 3D TEE is helpful, and you can see it, but as you can see, the resolution is not as clear as CT, and I cannot see calcium. I can see calcium on CT, I can see fat better on CT. So that's enough didactics. Now we're going to start shocking you. The case studies we're going to go through is to help you think, what is the best valve for your patient? There's going to be over 8 different valves coming in the next 10 years, different sizes, different appearances, different industries. How are you going to select the best valve for your patient? First thing that we're going to keep you thinking about are take-home points, infraannular calcium. It's very important for valve selection. You want to differentiate this from cusp calcification and relationship to the LVOT. And at the end, you want to anticipate a leak on a TEE. So infraannular calcification, when we're showing this, on the far left-hand screen, the green arrow shows aortic valve leaflet calcification. We don't care about that. That's what anchors the valve to the aorta. What we care about is the actual black arrow that says infraannular calcification at the left coronary cusp going to LVOT. That's a 3-chamber view. Why is that important? Because these valves are made of metal. And if you think about it, it's almost common knowledge that you can't put metal against metal, it doesn't conform. So that's why you need valves sometimes that have skirts or stuff that has fillers that can go around that area to stop a leak. So if on my right-hand screen in the angiogram, they see this and there's a significant leak, but on my TEE, I don't see the leak. The question is, where is my cross plane? And this is what we need to understand in echo. Our echo technology right now and our understanding of sweeping and looking for leaks is actually probably underestimated. Our paravalvular leak is probably underestimated in the echo lab because we don't look for the leak. We don't sweep for it. And primarily because we don't see anything in 3D. 2D echocardiography is what we're trained in, it's how the textbooks are written. We don't have a 3D model for echo textbooks at all right now. So both our sonographer training, our fellowship training, we don't see in 3D. It's very scary for 2016. So on the far left top screen is a mid-esophageal short axis aortic valve view. TAVR valve is put in, and the blue is going in and out and fine. There's no leak around that valve. On the bottom left-hand screen is a leak at the 4 o'clock position, a paravalvular leak. The reason and the difference is primarily on the horizontal planes. Those white boxes you see on the right-hand Cath images show where we're cutting the actual valve using our sonographer technique. But there's no way for us by echo right now to know exactly if we're cutting the cuts correctly at the right level. The leak is low. What if we're cutting high? Then it's going to be read out as no paravalvular leak, despite the Cath report saying something else. So what's the best view? Merging CT and TEE, deep transgastric view, is the most important view. Because this is how the flow of blood is going. And remember, the key is think like a device. What is the device doing? And stop thinking like the actual exercise physiology. The blood is going parallel to the valve, so we should be scanning parallel to the valve, because that's how we're going to see the paravalvular leak. So on the bottom left-hand corner is the probe is in the stomach, and you see these wispy fire flares on the left side, right side, those are leaks. And again, leaks are not good for our patients. They have 50% mortality if they're moderate to severe perivalvular leak at 2 years' time. Other problems with infraannular calcium is where do you measure? Common question in TEE and common question in CT. The easy answer is we don't know where to measure because there's no such thing as the aortic annulus. This was published in 2011 in a scientific journal and had very major impact in defining the definition of aortic annulus. What's very important to understand as a software in industry and as a technologist, stenographer, and a cardiologist in measuring this, there is no such thing pathologically as an aortic annulus. It was scientifically created so we can do repetitious measurements at the same point over and over and over. You have to think about the aorta as a tube. So this is where 3D imaging is helpful. Still don't like the green color. This needs to be a better color. So with the imaging platforms here, you can actually see this aorta as a tube. The minute you start thinking about planning as a device and implantation as a device, you'll realize that will this tube fit on top? Will the tube fit on bottom? Where am I going to have the leak? Is this the right valve? That three-dimensional view is what our sonographers need to be able to see, our fellows need to be able to see, and what our CT techs need to be able to see. It's beyond the grayscale, and so our interventionals need to be able to see too. So what's the role of 3D print? Not everybody believes imaging. Imaging is voodoo, is what we've always been told. But if you make a 3D print model, which you do not need for TAVRs, for all your cases, only for the complex ones, you can actually get the accuracy of the patient's scale to 1.25 millimeter slice thickness, or whatever your CT scan or MRI slice thickness is. And you can actually feel in your own hands the shock factor to scale. What does that leak mean? And that's where the education comes in with this. So in 2011, we were undersizing because we were measuring diastolic phase, so our valves had severe leak. So in 2015, we married two different valve companies, the Core Valve and Edwards. So we treated this leak by using a 3D model, 3D print to see if where we should land the valve to close the gap. In 2015, this patient flew up from Florida and got a core valve within a 23x T valve that was undersized before because it was a diastolic phase, and went home and played golf and did fine. So that was infraannular calcium. Next thing to take home is aortic root calcium and catheter coaxiality. What CT can show you and what TEE will anticipate and what the fluoro lab needs to know. Learning to anticipate is the bottom line for the echocardiologist or interventional imaging, whatever you want to call yourself. Top left-hand screen is the aorta. White is calcium. Calcium is bone. Calcium is like metal. It's hard. Calcium is not good. Bottom left-hand corner is the same patient's transesophageal echocardiogram. You don't see that calcium very well, but you see hints of whiteness that are more bright than others. What does that mean? On the far right screen is the deployment. This is a balloon valvoplasty. You get this valve opened up so you can put a valve across. What you're going to focus your eyes on is the balloon opens and then bursts. So see, that's bursting. So we're going to play it again. Balloon opens and it ruptures. That can cause a stroke. It does cause strokes. Sometimes it causes stuff to fly elsewhere. When the balloon bursts, it's because there's a calcium there. Anticipate. You saw in the CT scan, you saw in TEE, and one thing is the catheter was not coaxial, so we favor the calcium to burst the balloon. Other things take home point is the sinotubular junction. In echo, we don't look at the STJ. We measure in diastole, but we see in two-dimensional view. Got hips. In Detroit, we call it got hips. So what's important about having hips? Men and women both have hips. There's no gender preference or not. And there's calcium at the hips sometimes. The hips is your sinotubular junction. And what's important is measuring the diameter of this to see if this is actually going to accommodate not our valve, but our delivery system. So for balloon expandable valves, it's very important. When we do an aortogram here, you're going to see that this patient has hips. You have the aortic cusp on the bottom, and then you use narrowing point before it goes up to the ascending aorta. For balloon expandable valves, the expandable balloon is actually twice the size, if not 3 times the length of the actual transcatheter heart valve. So as we're deploying this, you're going to see this balloon deploy. And this is an S3 valve. And as the balloon goes up, remember that shot. 2 things. Did you notice there's a premature ventricular contraction? So the heart screwed us. As we're deploying the valve, we rapidly paced the heart at 180, and then it jumped 1 beat, and the valve actually jumped higher, which is where our coronary heights are supposed to be very important. When that happens, we all have palpitations, along with the patient too, which is why there's a wire there. But the next part that was important is the colors of the lines. The blue line and the green line, if you look closely, are not the same diameters. If you look at the balloon itself, the balloon at the aortic root is actually smaller and narrower than the balloon in the LVOT, the left ventricle. The balloon could not expand fully because sinus junction was small. When you have this, we had to rush and put a second balloon in so the valve would actually function. Patient did fine ultimately at the end. What's important is there's different types of valves available. We talked about SAPIEN 3, XTs, and core valve. This is the same patient, different patient, that has hips too. And again, the sinotubular junction is small. This is what this valve looks like. It's got bumpers on the aorta side and bumpers on the ventricular side. Echo is very important to know what valve you have. We emphasize a lot to our echosonographers, make sure you have the right valve in there so we can figure out what gradients we have. The patient on the 1-month follow-up echo had a velocity of 3.6 meters per second. That's like moderate to severe AS already, and they started with only 4 meters per second. A 1-month follow-up echo, we should not have a gradient that high or velocity that high. So on the bottom left view is a color flow through the 5-chamber view, and you can see a lot of color turbulence or rainbow color aliasing in where the valve is at. On the right, you don't see that color flow, but you can see that the valve rim is pushed in, and I apologize on the pointer, so I'll show on a different slide. The velocity was fairly high, 3.4 to 3.56. And Guillermo went back, because I was like, Guillermo, it can't be possible. We put a valve in, the patient should feel better. So he went back and got me another one. He actually labeled this one, says, not MR. This is an MR jet, that was the AS jet. So I knew for sure this was AS, but why did this happen? So we go back to the pre-TEE and intraprocedural TEE. The TEE image shows exactly what happened, and this is what we got to anticipate. There's a chunk of calcium that you already see where the valve is at. On the right screen, you see that chunk of calcium labeled at the sinotubular junction. That calcium prevented the valve from fully inflating. When it did that, there was actually a central leak for this valve too. The importance of this is actually a retrievable valve. So since then, our protocols are, this valve could have been repositioned. We check for gradients, check for velocities immediately after the valve is put in so we can change and adjust that. This is an impact of calcium, and we're checking for gradients, intraprocedural and TEE before letting the valve go. And unfortunately, that was the only valve that that patient could get because they had a metal allergy, and that was less than optimal result. So when you take a look at this TEE right here, this is where color flow is extremely important. It's not just about the velocity, where is the velocity? So on the far left screen at 9 o'clock is going to be your left ventricle, 12 o'clock is your left atrium, and where the arrow is pointing is turbulent flow, or the orange. The high velocity flow is no longer where the aortic valve is at. It's been pushed back to where the sinotubular junction calcium was at. That's what the narrowing is. It's actually iatrogenically induced supravalvular aortic stenosis. Try to publish that one. So intraprocedural, you can see the aliasing on the left-hand screen is more towards the left. On the far right-hand screen, the color flow turbulence is more towards the right. As echocardiologists and echosonographers, we want to capture that when we're looking at this, because when you have a velocity that's high, there must be a reason that the valve is not functioning properly. It's not ever going to be normal. And both of them were at heart rates that were low. So this was a Cath film that was done, the aortogram. And you can see the left ventricular outflow tract, the inferior part of the valve, the bottom part of the valve, looks more flared than the top part of the valve. And when we move this around, you can see the bottom part is more ellipsoid, top part is not very open. This was a retrievable valve. We could have repositioned it had we known. As you can see, where the hips were at, we unfortunately landed right at the hips with the valve. So we made the area there even smaller. So that's why hips matter. They can rupture the balloon, they can prevent a valve from functioning properly, and it should be taken note of in the echo, TEE, and the CT, both pre and post gradients, and flagged. That's enough about TAVRs. So, like I said, TAVRs are old. You can get away with TAVRs 80% of the time with no complications with the software we have nowadays. We're going to move on to MitraClips, a bit more complex, a little bit more concerning. So, is CT needed for MitraClip? No. Why are we putting CT and MitraClips together in this talk? Because the mitral valve anatomy is better understood if you understand CT. There's a role of CT and 3D print in understanding mitral valve anatomy, and we'll see that more so when we do transcatheter mitral valve therapies in the future. The MitraClip system is actually just a clothesline system. It's a really big hunking device that goes through the femoral vessels, and on the left-hand screen is the clip itself. It actually has little barbs on the inside of the clip, and it grasps the leaflets that have a big gap and closes it. No CT is needed for this. It's all intraprocedural TEE guidance. No actual contrast is needed for this procedure. It's just fluoroscopy and TEE with a good probe. This is an assembly system. There's knobs, there's hardware, it's huge. It goes from a venous access and goes to transeptal sheath delivery system. And this is how it's set up. There's actually a little assigned MitraClip stool that's given to the patient, and we put the device on top of that, and you have to have 80 centimeters to the chest wall for the atrium. This is the rendering what the clip looks like from Abbott, and you can see the clip is actually on the outside of the leaflets and just grasp it and clothesline it in. On the top left-hand screen, you can see a very severely prolapsed leaflet. It's just going up and down. There's a huge gap between the two leaflets. On the bottom left-hand screen is that patient after they had a clip. And if you think about it, it's like going camping and putting a tent up. You're nailing stuff down. Well, with the clip, we're actually clotheslining like a laundry, old school, closing it up. The difficulty about mitral valve anatomy is probably the bane of any cardiology fellow's existence. When I was a first-year fellow and I got complex valve anatomy, I was like, oh, great, this is going to take another hour or 2 hours. But these are the studies that are really cool now because the way to learn them is actually not by memorizing where your leaflets are or the complexity of them. This diagram to me is too complex. It needs to be simplified. There's no way that it will ever be reproduced in a patient's body because nobody ever has a perfect body. Depending on how big your heart is, how big your vessels are, and if you're post-open heart surgery, you may rotate it. The way that we see a mitral leaflet in echo is basically as a thin strand. So what you see moving are the mitral leaflets, the anterior and posterior leaflet. On the left is 2-chamber, on the right is a 3-chamber view. This is how all cardiology fellows are trained. But in honesty, that's not what a leaflet looks like. So this is a 3D print. So this is a role of 3D print in educating, but not actually needing to be done for a MitraClip procedure. On the far left-hand screen is a reproduction of a 3-chamber view for the patient. And you see left atrium on top and left ventricle on the bottom. And you actually see the actual mitral leaflets. The question is, where are you cutting the plane? So the middle one is looking from the top of the left atrium into the left ventricle down, and you're seeing where the mitral leaflets should be. That yellow vertical line is where the plane you're cutting, or we think we're cutting. And that blue surface area is an anterior mitral leaflet. There's no way for us on TEE right now to know exactly if we're cutting A1, A2, P1, P2, A1, A3, but we teach our fellows that in the intercommissural view, you're guaranteed that's going to be A1, A2, A3, and it's going to be a P2 popping in and out. And then the 120, 140 view is going to be A2, P2. And our poor fellows are always memorizing that, and they always forget it, and we beat them up for it. But it's actually, they're right, it's not real. Because we don't have that much control, not that good. We underestimate the severity of mitral regurgitation by TEE and by echo, because we don't see what we don't know we're not seeing. So on the left-hand screen is probably mild MR is what was called on TEE report, and I agree with that. On the far right-hand screen, that patient's 3-dimensional TEE. And if you take a look at 3-dimensional TEE, at the 4 o'clock position, there's a whole huge P2 flail leaflet there. So this same patient is actually this patient. Where did we cut the plane of TEE imaging? We don't know. Our technology doesn't show us that. Our echo probes don't give us that. We don't have a good enough 3D volume to see right now where it is. So it's the blind leading the blind, because in this same patient on the top right-hand screen, it was mild MR. Same patient, bottom right-hand screen, we move the probe back and forth, is severe MR. And that's what the 3D is helpful for. The 3D is helpful for us to say, what's the pathophysiology? What is the true anatomy of this? And you know what? We were cutting in a different plane. So the first one, we were cutting anterior. The second one, in the bottom right-hand corner, we finally cut it. We were cutting posterior. But we wouldn't know unless we scan the 3D TEE image to see what the mitral valve anatomy is. That's something that has to be done in the lab to actually see this. Because on a 2D echo, you'll never see it, because the echo is always done by time you get it. This is that leaflet now in a live 3D acquisition. So you can see all the canopy going up in the left atrium here, and that's the patient's anatomy. So when we're having this, on the far left-hand screen, you can see the severe mitral regurgitation, all the color flow going to 1 o'clock. That's not normal. On the right-hand screen is the clip and the reduction of the MR. When it works, it's great. It's only trivial. So on the bottom left-hand screen, you saw was an actual 3D view of the leaflet. On the right-hand screen, you can see we stopped the leaflet from moving and we clipped it. But that's the benefit of CT and 3D printing. Where is the clip arm? One thing is to show you the degree of severity of MR when you're trying to analyze the mitral valve beforehand. So key point is to sweep the mitral valve, look at all the different views. The other thing is identifying device catheters. Where's the device, where's the catheter? And you don't have much time. Traditionally, when doing MitraClip, we do a transeptal axis. We go from the right atrium, we tent across the left atrium, cause a hole. And we look for the catheter tip at the end because we want to make sure we're in the left atrium. So that big white thing that's stagnant in the top right-hand corner is the catheter clip in the left atrium. And on the bottom is a change in angle of the catheter tip. I don't know about you, but I don't know where I'm at. All I see is a big piece of plastic in somebody's heart, but I have no clue where I'm at in the left atrium. And that causes problems. This is the view that you need to show. 3D zoom, or a full acquisition of the left atrium to show where the catheter is at. And you see the catheter is extremely anterior to the anterior wall. At 12 o'clock where the aortic valve is, that part of the catheter tip is touching the anterior wall of the left atrium. That's not good, because we didn't know that. What's the problem with that? Well, we kept on doing the case. We aligned our clip arms in different interconventional views. On the bottom, you see the beautiful 3D image of the clip arms on the lateral side of the MitraClip. We're about to put the device in. The problem, though, is this is what I missed. Pericardial effusion. I was busy admiring the MitraClip here and getting my 3D view and saying, I'll teach the fellows about this 3D view. But if I play this again, what you're going to see, take a look again. Your eyes are not going to be focused on the clip. Look at the left ventricle border at 4 o'clock and 5 o'clock and 6 o'clock. It's already a pericardial effusion. It took me 5 minutes to actually see that. Why? Because we're always looking for pericardial effusions in the 4-chamber view, in the 5-chamber view, in the subcostal view, in the transthoracic echo. If you think about a patient and the way that we're designed, our ventricle by gravity is at the apex, right? So by gravity, where would the pericardial effusion be first? At the apex. So you will not see in the 4-chamber view or the LVOT. By the time you see there, it's already been too dangerous. So this patient had a large pericardial effusion and cardiac tamponade. On the top left-hand screen of the Cath, you see that there's wires all across the pericardium, and they're draining the patient actively. The patient had to go to the operating room to get this repaired. They did fine. They weren't happy when they woke up and had a sternotomy. So the take-home point is, when you take a look at this, let me go one more time. On the far left screen is actually the probe. For our fellows, this is what a probe looks like on the deep transgastric view. This is how much anteflexion you have, and when you're rotating it, that's how you sweep, because that's where you're going to see the pericardial effusion first. A CT can show you this, because in CT anatomy, you see the apex of the heart is there. It's just putting two and together. Duh, gravity works like that. That's why MitraClip and CT or 3D printing is important. More for just teaching the echosonographer, echocardiologist, interventional cardiologist to understand the anatomy of where they're going in and where to do transeptal access. But now we're going to go to the new cool stuff. Mitral stenosis, mitral regurgitation. TAVR is here to stay. We did the first transcatheter mitral valve implantation in a severely calcified mitral annulus a year and a half ago. We now do transcatheter heart valve implantations in the mitral positions in degenerative rings and transcatheter heart valves in degenerative bioprosthetic mitral valves. You almost question the surgeon now, why are you putting a mechanical valve into a patient? If 10 years down the road it's going to be bad, they could just get another transcatheter heart valve in there. You can't do much with a mechanical heart valve, you need open heart surgery again. So in 2014, we did the first in-man transcatheter heart valve implantation in severely calcified mitral annulus. All of us had palpitations that day. So the one thing that we learned from this that's actually scary is CT is not enough. I just told you how great CT was. I told you how great TEE was, and now I'm telling you that it's not enough. And this is where I live in fear, because we don't have technology that we need for the cars for our patients. On the left hand of the screen is the left atrium and left ventricle view of a calcified mitral annulus. Again, CT can show you calcium, echo won't. You can see all that white gunk. Where do we measure? We don't know. If we measure one in the blue, it's one valve size down. We measure one in the pink, it's one valve size up. I've got ugly images of valves that have embolized before, and then we also have this on the right-hand screen. This is where computer-aided design comes in. You need a three-dimensional image of this valve to see where it's going, what it actually looks like. Because it's not about actually where the mitral annulus is, it's about where you land the valve and personalizing this patient's anatomy. This is a patient with a transcatheter heart valve and a degenerative bioprosthetic. The question is, do we do this patient's case or not? By CT, we do transapical mapping, find out where the LAD is at, and Dr. Ian's going to come and talk to you about that shortly later. And on echo on the far right-hand screen, you can see we don't see tissue definition. We don't see the LAD. We just see a lot of body mass and body habitus there. We take the CT scan and make it for the interventionalist. This is what CT has to do and what echo has to do. We stop thinking about ourselves and think like a device. CT for the interventionalist is mapping where the LAD is at so we don't poke it because we call it tamponade. Where's the rib space so we go through that? So this is what our 3D lab does, and they're beautiful artistic renderings, which is actually real. This is before we put the left arm down. And this green and red cross here is our transapical access site. We need to know, what are we going to hit when we go in there? What is it that we're going to try to do, and are we going to the valve? And by the way, what is the lung doing? So that are we going to actually cause a pneumothorax too? This is that patient that we did in the first in man. Far left screen is that transapical rail. See the catheter going through that trajectory that was determined by the CT scan beforehand. Far right is us pulling the wire outside the patient's body and having a valve for this delivery device. When we do it in degenerative bioprosthetics, in the left you can see the valve's not functioning well. On the right is a new valve put in there. When it works, it's beautiful. However, one thing that we're not showing is critical LV outflow tract obstruction. If we cause complete blockage of blood flow with the valve in the mitral annulus at the LV outflow tract, we can kill a patient on the table within 5 minutes. So there's actually very good free apps that everybody should download on their iPhone or Android that can tell you what valve to put in for a surgical valve. Has all the surgical valves mapped out. What's not good about this is that there's just a false sense of complacency. With TAVRs, we've gotten good enough. With mitrals, they're deadly though. It's one thing to put a valve in a surgical valve. It's another thing on the far right rendering, you look at a valve from the top into the ventricle. But it's another thing to put a valve inside a patient's body habitus. So that valve that you just saw, if we implanted a valve into that patient's valve, we would cause complete outflow tract obstruction and kill them. So we actually told them to stay in hospice and not come to us because we have nothing to offer. So in this patient in far left, what's most important is seeing the neo-LVOT, there's a new left ventricular outflow tract that we create when you're going through CT scanning. Understand the role of the 3D print. And when you don't know how to measure, the 3D print comes into view because you can put a valve in there and figure out what it's going to look like and mock up the devices. With computer-aided design technology, you can tilt the valves angular, anterior, posterior, and figure out the surface area you have left over too. This is how we're doing our prediction modeling for left ventricular outflow tract obstruction here for the mitral clinical trials. What we're trying to do is personalized medicine, which we should be striving for in 2016. On the far left-hand screen is a patient that we could have killed. If you put a valve in the ventricular outflow tract, there's nothing there left over. Everything is completely blocked. This is what we should demand of centers who want to transcatheter mitral valve implantations. And this is what we want you to go back to your hospitals and say, hey, for insurance, for industry, you should demand that hospitals be this level of safety because we can do a lot because we don't see a lot, we don't know that. But for all this to be understood, you have to start with the basic imaging and understand what the 3D anatomy is. So the bottom line of the question is this the right procedure for that patient? No. Because now you don't look at the valve anymore, you can look at the aorta and the outflow tract and see that the valve is touching. So this is a 3D printer. Mike Forbes and Eric Myers are excellent 3D designers. They were CAD designers by training who have now become pseudosonographers and CT technologists in segmenting. Whether they liked it or not, they started learning this, and they're excellent pioneers in this field. And these are just mock-ups of different patients with valves. On the far right hand, the patient had an aortic annulus of 1,000 square millimeters. We had no valve for them, they died. So one size does not fit all. So on a better note, you can use 3D printing to figure out what valves to go in. You can use it to sway. And the middle part is a surgical valve that failed. On the right is a 26 valve, and the far left is a 29. You can see which is going to be better. This patient got 29 XT, thought it was going to be too big. We did 26 XT, and her name is Betty Niemi. She's doing great now. So 3D printing can help you in sizing. So when we presented this at ACC, we looked at the audience with the question, if you or your family needed a transcatheter mitral valve intervention, how would you proceed if you're not a surgical candidate? Would you go A, to a center that has timber evaluation with CT, echo, CAD, and 3D printing? Or would you go to a center with timber with CT and echo? Or would you go to hospice? 20% of the room raise hands for C, appropriately so. 80% raise your hands for A. So this is where computer-aided design comes in. If you're going to do mitrals, you want to be that level of safety. On a lighter note, in conclusion, there's new frontiers. I told you we put devices in other parts of the heart or stuff that's close to the heart. So on the far left-hand screen is CAVI, cable valve implantation. For severe tricuspid regurgitation, we put 2 endobrachial stents in the far left-hand screen, narrow the IVC down, and then put a transcatheter heart valve upside down there to cause a blockage of valve leakage going into the hepatic vein and prevent ascites. And the far right hand is a mock-up of that in a 3D print and sizing it. What you can do on echo is using the CT scan, you can get the same right atrial and IVC images because then you can see that the struts are not going through the foramen ovale or fossa ovalis and causing an iatrogenic ASD. This patient from this therapy got 18 more months of life left before she passed away. On the far left of her screen was before the procedure, far right was 4 months after the procedure, her pleural effusions were gone. So this is kind of our medical imagineering, or where we're hoping to go with structural interventions. merging CT, TEE, and technology to come, where we hope that when you guys walk around today, I want that all of you take a look at the different, I want to say toys, but that's kind of demeaning, not respectful. All the new stuff that's coming out, augmented reality, put those 3D glasses on, see the virtual world, because that's what we demand of our hospitals and our technology to get our patients to the next level of safety. Thank you.